This week on the BackTable podcast.
That expensive is missing a cancer because you're trying to save $300 on a procedure. Expensive is taking a patient back 2 and 3 times to the OR, maybe the same doctor and then somebody else, but some patients go multiple times within a year, 2 years' time to get a treatment that they could have had. And you're right, sometimes I get to be the lucky person because someone else didn't do something. And my point is, if I could have on my tombstone is that she tried to encourage hysteroscopy.
Discover the Medtronic solutions for women's health. The TrueClear Tissue Removal System is a hysteroscopic tissue removal system intended for use by trained gynecologists to hysteroscopically resect and remove tissue such as submucous myomas, endometrial polyps, and retained products of conception. The TrueClear system offers a complete solution for diagnosing and treating intrauterine abnormalities that may be causing abnormal uterine bleeding. Learn more at medtronic.com or talk to your Medtronic representative.
Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got, once again, return guest, good friend, and true expert here with us, Dr. Linda Bradley. Linda, good to see you again.
So great to see you, Mark. And again, I'm honored to share with you any insights, clinical pearls, advice for something I'm so passionate for the past few decades. Thank you.
We're very lucky to have you. And for our listeners who don't know Dr. Bradley, I can't imagine there are very many of you, but she's a professor of obstetrics and gynecology and reproductive biology at the Cleveland Clinic. She's the director of their Center for Menstrual Disorders, Fibroids, and Hysteroscopic Services. She's the past president of AAGL and their current medical director. She's an internationally recognized expert and innovator in advanced office and operative hysteroscopy. We could go on, but again, we're limited to about an hour, so we'll stop there. But for all your accomplishments, we appreciate you making time for us. And today we're going to pick your brain about direct visualized endometrial sampling. And this is something that we've talked about for a long time. I've thought about for a long time, but I know there's some new data out there, some new literature, and I know there's a lot of opinions, and no better opinion than yours. So welcome back to the show. And as we like to do, can you just give a little bit of background, sort of what got you to where you are in your practice and how you got into becoming an expert in this?
Well, thanks again, Mark. So I'm very fortunate to work at the Cleveland Clinic, a huge enterprise in Cleveland, Ohio. And as you know about our institution, many individuals tend to choose a passion project, something that's different, unique, and then develop it, explore it, innovate within the area, and then become the go-to person, and also to teach and to train. So I started the Cleveland Clinic about 3 decades ago, and I started at the time that only thing that the doctors were doing, even at the clinic and the Department of Gynecology, were blind sampling, or as we now know it, dilation and curettage, or dilation and cross your fingers and hope you got everything out as a procedure. And I had happened to begin learning about hysteroscopy through meetings, actually through the AAGL, because during my residency, there was no hysteroscope. I was of the era, you do 3 blind DNCs, you miss everything, you miss the focal lesions, the patient with post-menopausal bleeding still bleeds, and you do your vag hys, or you do your hysterectomy. So this is something that became evident to me the further I was away from training, that boy, am I missing, not I, but are we missing a lot being blinded and not looking. So I was very fortunate at the time at the Cleveland Clinic. That was going to be my passion project, and to offer hysteroscopy to our patients for the evaluation of bleeding. And from that, it grew to companies asking me, how many laparoscopic tubal ligations do you do? Because they were studying, hysteroscopic sterilization. I was a part of to be a VAC trial, another trial with endometrial ablations that required hysteroscopic expertise to have better outcomes. And so basically just being at the clinic, I think, and without having anyone else that showed interest at that time, I just sort of took this idea. There are so many patients with problems that I'm very fortunate. I don't think I could leave the clinic and say that my practice is only in seeing patients with menstrual disorders, alternatives to hysterectomy, evaluating abnormal endometrium on ultrasound or saline infusion sonogram or even MRI, learning how to take care of the patients with the difficult cervix that you can't even get into. So I think just being at the clinic with numbers that I was able to accrue a large number of patients in a short period of time, began publishing abstracts, publications, book chapters, my own book, doing live telesurgery for 3 major organizations, ACOG and AGL twice. And so, it kind of one thing begat another. And so I think at the clinic, whether it's our HVI or our Heart and Vascular Institute that has, one of the highest numbers of cardiac cases, we at the clinic, whether you do robotic, single port, vag his, folks just end up getting large numbers and have a very solo practice for the most part. So, tomorrow I'll go to the office and then, after talking like this today, I'll have a bunch of annual exams and PAPs. But I don't see patients for annual exams and PAPs. It's really problem-focused patients identified with some of the things that we just talked about. So, lucky to be at a large institution. But I would say even for a generalist, there's enough patients with problems if we listen to their stories to warrant hysteroscopic visualization and then subsequent treatments.
No, it's always interesting to hear how people became interested in or had the opportunity to focus and sort of follow their curiosity about a problem. And you talked about, doing a DNC or a blind office biopsy. And I think we all sort of had that feeling, well, I hope we get it. We've had more experience these days with operative hysteroscopy and those kinds of things. But there is certainly when I was training a little bit after you, there was the idea that blind biopsy was comparable to visualized biopsy. And now that I'm a hospital administrator, I think a lot about cost. And so let's start with the evidence for patients. I guess let's even go back further. Talk to us about what direct visual endometrial biopsy is or how that differs from traditional blind biopsy techniques, and in what clinical situations might you do one versus the other, or do you ever do blind biopsies, and sort of how you approach sampling the lining of a patient with abnormal uterine bleeding.
So, tomorrow I work with a med student and a resident. So I never want to say never, but most of my evaluation will always be with looking. It's like you don't reach into a refrigerator with your eyes closed to get milk or to go and get a fresh orange or pickles in the back of the refrigerator for a condiment, right? So to me, there's no other specialty when you have a bleeding problem that people don't look. General surgeon, colorectal surgeon, cystoscopies, ENT. So I think, the technology has been there forever. It's just that we have been slow to adopt. And like you just said, we think that the biopsy alone, blindly just taking a sample, well, what do we know? Higher perforation with let's just talk about Pipelle biopsies. They only sample a small percentage of the lining of the uterus, about 4.2%. You read some studies, maybe 10%. You miss focal lesions. They're classic studies, without naming all the papers and all of that, classic studies where lesions are missed. And so, how do you go and tell a patient that the normal endometrial sampling is only for the tissue that you got, but we missed everything else? So in premenopausal women, up to 60% of them may have focal pathology. They bleed, they continue to bleed, and eventually they're going to ask for hysterectomy. And I think it's very sad and pretty sobering to even do your 45-minute vaginal hysterectomy for a large polyp or a polyp that was missed or a fundomyoma. So to get back, sampling misses, there's false negative rates. What do? You miss all of the beauty of the endometrium in terms of where a patient is in her cycle, looking at transformations from hyperplasia to cancer, focal lesions that sit up near the cornua or sit up near the fundus where we don't sample it. You miss your Mullerian anomalies, your septate uterus, your bicornuate uterus, your arcuate uterus, your Asherman's or small or large, your ability to see that isthmocele sometimes. And so I think, it's more than just sampling the endometrium, but it helps with your management and it helps the patient seeing is believing. And so I think for all, accuracy is number one, safety, effectiveness. And you end up, some patients, some studies have shown that patients end up with 2 or 3 procedures with a blind sample only, that results are allegedly normal. They keep having symptoms. Why, doctor, am I still bleeding? Well, you never looked, and so you take them back. So as an administrator, people are spending more money. Yes, there's an upfront cost for hysteroscopic equipment, some training, but your nurse, your students, those who are with you, man, you put that HD camera in and you just see everything. It's pretty amazing. And you know what you've got. And, now we're looking at see and treat for some cases. For me right now, if doctors would just look, if they just look, that would make me happy first. Then we can talk about treating, how do you remove a polyp or fibroid, retain products of conception, a missed abortion. But let us look, instead of, for the patients with recent pregnancies, a small little piece of placenta can bleed for weeks to months. You know what I'm saying? Leukorrhea, discharge, cramping. I think it's real-time assessment, and then we can expand its treatment based upon what we find, what we see. If you need specialized equipment in the OR, who does the procedure. I mean, we can go through all of that through informed consent. So I think that it's just a beautiful procedure, and I just can't think of any other specialty that we look at. And then lawsuits, missing endometrial cancer when you haven't looked, that's a problem. Okay, missing intracavitary fibroids that have been there and someone cannot have a pregnancy or a large polyp or whatever that's there. You know what I'm saying? Foreign bodies. I've seen IUDs that patients forgot that they had in, portions of IUDs that were left, perforations of IUDs, and you can follow it and be able to retrieve it. Some of these things cannot be done in the office, but to me, if you can first see, look, evaluate, and say, in my hands, can I do this? Do I need to work with a more senior person? Do I need to make a referral? I would say see first, and then we can talk about treatment. So this blind sampling doesn't get you anywhere unless you happen to get the pathology. And then, Mark, do you know if you got the whole polyp? Do you know if you got the whole fibroid? What's your endpoint? And so
I think historically, though, most of us get ultrasounds, right? So someone comes in with irregular bleeding, get an ultrasound. If it's totally normal, how often are we missing a focal lesion, a focal polyp, a fibroid, or retained products?
Let me just ask you, I saw a patient yesterday. She's 67, since 2016, has post-menopausal bleeding a little bit, 2 or 3 days, every other month since 2016 with an endometrial echo of 2 millimeters. Okay, multiple endometrial biopsies. What would you do? Now, I saw her first time yesterday. Have her, like you said, she has an ultrasound. Some of the biopsies, no tissue. Some of the biopsy, inactive endometrium. Some of the times they haven't been able to get in, but her symptoms have persisted. I mean, this is a typical kind of, so let me kind of, if you don't mind, what would you do? And then I can tell you what I'm going to do.
Yeah, so if somebody comes to see me, post-menopausal bleeding, 2 millimeter stripe, and they've had one episode, then we watch. If the bleeding continues.
2016.
Well, right. So I'll tell you what I would do.
4 doctors she's seen. I'm just telling you. I wish I could pull up the chart and show you, but yeah.
I would say reassurance. Okay, she comes back. I said, if your bleeding continues, come back and see me. Okay.
Okay.
Now we're saying it's every other month. Comes back to see me. Ultrasound's normal. We'll just do a biopsy, make sure there's no cancer. Now, if we get normal, non-cancer, then I'm, again, reassured for a little while. And I feel confident based on what I understand about the data that it's not cancer. Now, if her symptoms continue, then I'm not done. Then we look.
Okay.
So I've got an ultrasound to see if there's any focal lesions. We do a biopsy to rule out cancer. And if the symptoms continue and persist, then we have a pretty good reason to take a look, because ultrasounds can occasionally miss a little polyp, a little cervical polyp. You go in there and that's it. But I wouldn't personally start with that.
Well, I would. I start with that. So but it depends on how the patient comes to see me, because if you have a thin patient, a normal uterus, no adnexal masses, and again, you're asking about someone who's practiced. Someone asked me the most hysteroscopies I've ever done in one day in my office is 13. Okay. Somebody that's overweight, I can't feel, has a 20-week size uterus. Yes, I may get some other things, but I can see her right then, unless she's had a couple of things to go on. In her particular case, she had a cerclage, she had a set of twins, and she had another child, 2 C-sections for 3 children under cerclage. So I'm going to soften her cervix, and I'm bringing her back for hysteroscopy, because what you're going to miss, to me, with ultrasound, those small polyps, the uterus is compressed. It's very elusive, and polyps can conform to the endometrium. To me, at our hospital, and I did pioneer the term, and I think it was 1994, 1997, the word SIS. I have a paper was published in the Green Journal, where to me, if you're going to believe in ultrasound for bleeding, it should be SIS. Because you open the cavity, you can look for irregularities, you can look for asynchrony of the endometrium. But what you're going to sometimes miss are those small little polyp-like lesions near the endometrium, the tubulostia, things that go on in the cervix. There are lesions in the cervix that can be missed. So for me, I think because we have like 9 scopes, can reuse them. It's easy. Our nurses have things, if they have a tiny stenotic cervix in the history that this patient have, I'm going to treat her with several things to make the success better for that. So again, I think medicine's an art as much as it is a science, but I think the sensitivity for hysteroscopy is much greater than ultrasound. And I tend to reserve ultrasound. When I've done this and find nothing, we know that 3 to 5% of endometrial bleeding can be due to ovarian lesions. And I'll do an ultrasound for that reason if everything has come out normal. We've picked up fallopian tube cancers that are bleeding. You see a hydrocell, something swollen. Endometrial cancer can present, ovarian cancer can present. It's rare, but we all in our collective years of service see that. So I think it also depends on what tool you have.
Well, I think so. That's my next question. You're talking about Cleveland Clinic, where you have practice you've built with scopes, and you're doing 13 a day.
Well, the maximum. I don't want it to get out. On the average.
No, I got you. Yeah. So I'm a MIG surgeon. I've been doing this for 13 years now. I've got an Endo-C is what we've got, which is helpful. But there's also, I think most of us in our practices don't have access to that same setup that you've got. What I had in fellowship is not what I have in my current practice. And so for most of our listeners, I guess the question would be not what can you see, but what is the benefit? Again, if someone comes in, screen with ultrasound, if there's an obvious focal lesion, I don't need to do the office biopsy. I know I've got to go in and I'm not going to, so I actually do the ultrasound first, because I don't want to do a blind biopsy, then get the ultrasound results. So now I've got to go back and hysteroscopy and take a polyp out or do myomectomy or whatever. I'll get the ultrasound first, hopefully same day if we can get it. But if the ultrasound's normal, we can do the sample, rule out cancer, and then we have all the options in the world. I typically reserve visualized biopsy or hysteroscopy for folks that we've managed medically and failed in a setting of a normal ultrasound. And I guess what I would like to know is sort of why we should change that practice, not just because we can, but what does the data show us?
I'm not saying that you should change. What we know, in fact, that we're working right now on a huge guidelines group. We meet every other Sunday, AAGL, ESG, several, is an international group looking at just this question. I think what and that paper will be, hopefully the guideline paper will be out by the end of the year, beginning of the first quarter of 2026. It's not an either or. I like what you do. There's nothing wrong with it, because you are looking and then you're doing. And if the patient doesn't get better with your protocol, then you are going to go to hysteroscopy. You see what I'm saying? Or not going to just do something, a blind curettage. So I don't have a problem with that. And so...
Yeah, I haven't done a blind D&C in, probably since residency. It's been a long time, 15 years.
But there are a lot of people that aren't like you, Mark. I'm just saying, you and I get to travel We get to talk to people and we get to see this continuation. In the 1960s, 80s, D&C was the biggest procedure. And some people have failed to learn about new technology and incorporate new technology into their practice. The learning curve for hysteroscopy, you ask everybody, this is what troubles me. You ask someone your age, my age, you go to a meeting, how many of you are doing robotic hysterectomies? Everybody and their brother and sister raise their hand. You ask the same question about hysteroscopy every meeting, at most a third. Maybe we can get up to 40%. How many of you are doing blah, blah, blah? Everything else people are learning, but hysteroscopy has just been, it's been underutilized. And for the life of me, I can't understand for being
There's
able to
nothing
image.
more fun or satisfying than a good hysteroscopic case. Right? No skin to close, no one to round on the next day. Patients
Yes.
are happy. You've solved a problem. The true, initial natural orifice surgery, right?
Right,
No,
yeah.
Clearly, I think it's the thing I would say if I could get a practice like yours one of these days, I would like to do it now that I'm only 30% clinical. But I guess the question I would ask, though, is so office biopsy versus, that's really the question here today is I know there's a group of you guys. I know I've talked to Nash Moad for years about this, and there's sort of this contingency of folks that say we should never be doing blinded biopsies because we have the technology to look. And I think it makes logical sense, but what does the data show us?
Oh, the data shows more accuracy with directed biopsy. So the thing is, if you look inside the uterus and you have diffuse disease, and meaning you just see thickened tissue, yellow, necrotic, bleeding, friability, and it's everywhere. And studies have been shown that if you put up just a pipelle in, yes, if that's diffuse hyperplasia, cancer, you're going to get it. What has been shown is that when you have the surface area, if it's less than 5%, you're going to miss a large amount, less than 25%. So it depends on the size of the lesion. So if I look in somebody's uterus and it is just filled with stuff, even if I didn't have if she's postmenopausal, thickened endometrium of 10 or 20, but it's everywhere, I know that it's very likely using pipelle, or we don't use Vabra anymore. But when you look up there and you see a focal lesion by the cornea or the fundus, you're just not going to get that. You see what I'm saying? You're going to miss it.
What do we miss? I mean, it's one thing to miss a benign polyp, right?
No, don't take it so lightly. If you're a woman and it's summer and I'm wearing white pants and golfing and I'm staining and I have to wear a mini pad every day, I wonder about after having sex, am I going to bleed, stain, or spot? See, I think we minimize a woman's symptoms.
No, I appreciate
okay, so
that.
I will go to bat that it's not cancer, but it has changed your social dynamics. Asking, do you have a pad? Looking at the seat when you stand up, not wearing white. So I think any bleeding, no, it's not going to kill you. You don't have a hemoglobin of 2, but every blue moon you're bleeding when it's not your period or you're menopausal, and it's just you're worried about it. So I really want people to say, take it seriously. We're going to rule out cancer, and what you're going to miss are focal things. As I mentioned, 40 to 60% focal polyps and fibroids. There could be focal hyperplasia. Yes, you can have coexisting things, So I think what I'm saying is and I've done cases, postmenopausal woman, big, it's anecdotal, 2, 3, 4 centimeter myeloma, resected in the OR. Oh my God. And behind it is the cancer. I take it, I look at it, that fibroid was probably just present and a passenger. It wasn't the problem. The cancer was behind it, or it's up by the cornua. So, or you have a uterine anomaly and the cancer is you put your pipelle or your curette in and you're in the wrong part of the cavity. So I just think seeing is believing. You can't convince me that anything's better than looking. And I would say if it was your wife's sister, grandmother, or someone, and it kept bleeding, I think you would want the doctor to look.
I think you've brought up an important point. If the symptoms continue, we don't ignore that. I mean, I would never suggest that we ignore persistent symptoms just because your biopsy is negative, you're fine.
But
that's
doctors
like saying
do that. Doctors, this lady, they
that's
keep
a bigger
doing
conversation. Yeah, that's like the patient that says, I'm having pain for 15 years and your ultrasound's normal. You don't have endometriosis. Well, we can't say that, right? So
Right.
I think we start with basic good health care, which is listen to patients, believe patients, and start with that. But if the biopsy is normal, what I can tell them is not that they won't have symptoms or that I don't care about their symptoms. I can tell them that with relative sensitivity, with that they don't have cancer. Now, what they choose to do about how to manage their symptoms. Sometimes folks are like, the bleeding doesn't bother me. I don't want surgery. I just want to know that I don't have cancer. Okay. And so listening to what patients want, sometimes it's medical management. Is there a way to manage my bleeding with medication? And if they want that, that's fine. We can always take a look and see.
What medicine you're going to give them when they're 70?
Oh, if the post-menopausal is different. No, agreed.
Yeah. So I think we're moving from see and guess, Guess, to see and know with certainty. That's what I would want for me, my family, my siblings. I want to know certainty. And this is so easy to do. Easy referral to someone's practice. But it only takes 25 to 50 cases to get good at this, at least to know what you're looking at. You're not going to perf if you go in and you can slowly go through, see the beauty of the endometrium unfold before you, the tubal ostia. Your risk of perforation is so low, Yeah,
I don't dilate anymore when I do hysteroscopy. I just do my diagnostic scope and just walk it in. I mean, I almost never have to dilate, because if you dilate, you messed up the endometrial lining.
No, I totally, there are times you got ectocervical stenosis and a little endocervical stenosis. So I don't want to say never.
1 in 50 times I may need to dilate a little bit, but not much. But so I guess the question is, we can do it. Now, you have a good office set up, and it sort of makes it very easy. For those of us that don't, then the option becomes the operating room, right? So
no, it becomes being an advocate at your hospital and having a voice and being a thought leader and saying this is not 1990 or 2000. I think you have to have a strong voice, be a strong advocate, because this has been around. Our instruments are miniaturized. So I would say no. I would go to an administrator, and there's somebody that's smarter than me that can show you your return on investment. And we train, we have simulators, we have residents and fellows coming out of programs that are learning this. I would say that's not an answer for me. That would not, if I had to move and go somewhere and there wasn't a scope, I'm not going to say that no one would do what I ask for, but I think I would make the compelling point of view that this can be done in an office. And you mentioned at the Endocy, you don't even need a special room or a special tower for that. People were talking about taking these up to the ICU when you get the postmenopausal bleeding in the unit and they can't come down to the floor, or at the bedside in the emergency room with a seasoned physician. So I think we have to advocate. I'm not speaking, and I hope I'm not being rude, but I just think we cannot sit back, sit on our hands, be quiet about this, because this is an easy, adoptable procedure. The companies have just gotten so wonderful in terms of with real-time imaging. I mean, in the future, I'm not doing this, but 3D reconstruction, we're going to see new guided biopsy systems. And I think when you do this, for the administrators, those doctors become a referral magnet. Patients love you. Can you believe what I saw? It's like doing an ultrasound now and seeing the baby and almost, I'm just joking, knowing the color of the baby's eyes. Patient satisfaction. Oh my God, I can see what's going on. They're partners. Professional fulfillment. I mean, I couldn't be any happier when I figure out what's going on or what's not going on. And then those patients that have the 2mm echo, everything's fine, and it's just dry and atrophic. You can see the basal layer. You can see the blood vessels. You just can give them, with confidence, some estrogen for 3 or 4 months. It's sort of like Leon Spiroff was my chairman, the guru of hormone therapy back in the day. And when these patients have atrophy is atrophy. They're on Depo-Lupron, GnRH therapies. They're on what used to be Danazol. Somebody that breastfeeds for a year and a half. You look in that endometrium, it's dry. Atrophy is atrophy. And then you decide, hey, this is dry. Do you want me to give you without, I don't know why Leon Spiroff was right with this 2 months of estrogen patch or a pill of choice. For 2 months, you don't even have to give progestin. That endometrium is like, I tell the patients, it's like a moisturizer for your face or your skin. And they stop bleeding. And you might have to do it 2 years later, but it's not like a lifetime of hormone therapy. So I just think we took an oath to first do no harm. And I say, if I'm missing a diagnosis because we didn't look carefully enough, I think that's a form of harm. And isn't providing false reassurance to patients based on inadequate looking and sampling a form of harm.
So what is the risk of harm? And so I'm trying to find out if blind biopsy is sensitive up to 97%.
No, it's not. What is it negative? What are you missing? I mean, do you care if you miss, or does anybody care if they miss a fibroid or polyp or focal hyperplasia? You know, it only samples 4.2% of the endometrium. That's it. There's the study by Stock and Gambor, back 1975. I have the residents read that paper. Older guy at the time, I looked him up, did a vigorous DNC, okay, scrape into the uterus, cried. Then 20 minutes later, did a hysterectomy, and then asked the pathologist to say what part of the endometrium with a vigorous crying DNC, so to speak, is left untouched. Okay, a lot of it is untouched. The fundus, there's sort of gravitational force places where people aren't going to feel as comfortable. You may be more comfortable up by the fundus than I am, or by the cornua, where there's more risk for perforation. So, I think there's enough studies that have shown that what you miss, okay? I totally agree, and I think I got to think of the guy's name that says, yes, if you got a bunch of cancer, a pipelle biopsy, DNC is fine. But if your cancer is less than 25% of the cavity, you're going to miss up to 50% of the cancers, okay? 5% or less, you miss a lot of cancer. So, it's not just cancer, it's the symptom and concern about what am I bleeding for, whether it's between your periods. Some women with religious prohibitions, sex can't not happen. It's a pain. Yeah, you don't have cancer, but you got something we can treat and take it out, sometimes in the office, many times we don't do myomectomies in our office, okay? It depends on the size of the lesions and the patient's comfort. Has she had pelvic trauma, rape, incest, things that we're not gonna, you could push the envelope and do things, but some women have been so traumatized in their life that, for me, get a small scope in and look. Then we can say, Miss Jones, you just got a polyp that's this small. We can dial up and get a polyp forceps and take it up. Oh my God, you got a whole fibroid that's a type 1. No, we can't do that there. Blah, blah, blah. So
what percent of cancers do you think we're missing with the pipelle? Because the numbers you're saying, I'm trying to think back to what I learned. It was very, very little.
No, it depends on I wish, I know I have to do this live, and I do not have,
That's okay. We can always go back and put them in the show notes.
There is a study that just looks at what you miss depending on surface area. Yes, if you have 60, 70, 80% of cancer, pipelle biopsy will get it. You go in and out a couple of times. Just remember, how big is the uterus? Is it a 20-week size uterus, 16-week size uterus? Do you have any anomalies inside? Is it behind something? I know you're hammering on this cancer bit, but to me, it's beyond the cancer. Because most women don't have cancer, but they bleed. And for all the things I said before, it's not fun having this unscheduled bleeding. God gave us a 28-day cycle lasting for 3 to 7 days. And after you stop bleeding, everything's asleep. If you're bleeding outside of those parameters and nobody can give you an answer, and I think this is why we have too many darn hysterectomies in this country, because of poor evaluation. We can't find the solution to their bleeding. They get frustrated. They're missing work. They're missing activities. It just makes me pretty sad. I won't go over, there's so many anecdotes, but we did. I'm not going to mention when or where. We had an excellent speaker from somewhere in our country that said their emergency room sees 200 women a week who come in after hours, these essential workers, to get their blood transfusions. They can never get to a doctor to be seen. And what do these women want after their fourth or fifth? They stay all night, get their units to be pumped up, go back to work, and then they come in begging for a hysterectomy. What if they had an intracavitary fibroid? What if they had a huge polyp? To me, those are the saving graces. Maybe you could offer other things. So I think Our patients trust us with their most personal concerns. And I think that what we do, that we should actually look before we make conclusions about their treatment. So you've got me on I need more water, but I'm passionate about this. We had a case at the Cleveland Clinic. I was off because of family issues. And I took a walk one day and the patient had gotten 21 units of blood. Okay? I'm just listening on Zoom, taking my walk, go through, listen, they tried this, they tried that. I said, well, was there a hysteroscopy done? Apparently it was normal, but they got no tissue. Long and short of it, she gets a hysterectomy. So then I said, well, what did that's a hysterectomy showed fibroids. Okay, everybody, 80% of women have fibroids, 60 to 80. So I said, tell me more. What was the FIGO classification pathologically? It was all intracavitary. And so how do you explain her treatment? And it was only 4 centimeters. The person who ever hysteroscoped her didn't do it right, okay? You need to start at the lower uterine segment, slowly look in, get that uterus distended with your fluid, and look. So what they did was ride over the fibroid, saying that that wall was a normal endometrium. No, if they pulled back and started low in the cervix and looking, you see the big fibroid was just occluding everything. That was a hysteroscopic myomectomy case.
Again, these are ones though that we'd see on ultrasound, right? The big fibroids or big polyps. Those are things that oftentimes.
She had an ultrasound, Mark. You're acting as if everything is so perfectly beautiful. It's not.
No.
Yeah, it's just not.
No. But I think that really what I'm trying to focus on here is not about obvious or even not or less than obvious, but focal lesions that are visible in ultrasound. I'm talking about the ones where ultrasound's normal, and we're going to miss little things. But so there's two general questions. One is rule out something bad or not, right? Cancer or not. And the other is finding out if there's a focal lesion causing symptoms.
Correct.
And so we don't want to ignore the latter. We'll never not treat things. And that's where but this is a conversation I have with patients all the time, so what do you want to do? All these things are possible. We can do a biopsy in the office. What do you tell someone if you do an endometrial biopsy in the office with a normal ultrasound and they don't want a hysteroscopy? You do the biopsy.
I tell them we can still miss things, and that with looking with living color, we can just look and see what's going on. When I finish a scope, I can sleep. I look at my note. We take pictures. Our person in our department just said we're getting something new that can really be uploaded, like our colonoscopies. Our pictures can soon, I think it's coming in the next 4 to 6 weeks. The video can be in there. So it's a great teaching guide. I don't know the name of the company because I was not there for that discussion. But my point is, I just think hysteroscopy is the gold standard for looking when your ultrasound and your biopsy do not give you the answer to confidently treat the problem. So most biopsies are negative. And what does negative mean? To me, it doesn't mean anything. Only biopsies to me are only helpful when you have cancer. The rest, it doesn't help me at all. So for the most part. So I want to know what we're looking for. I think we're looking for excellence, and visualization is what we do best with most technologies and most of our subspecialties. So yes, biopsies, if someone comes, scopes down, can't do it, yeah, but you're going to come back because I don't believe in it. What's negative? That's my point. So, and there's too many things that could be missed. In ultrasound, you have technical issues with that. Do they see the whole, there's a parts of, what makes a good ultrasound. Okay. I actually think SIS is the best for imaging for bleeding. If I went to a new place and they said you could choose one instrument, I would get an ultrasound, but know how to do SIS, recreate your images, because SIS, not transvaginal ultrasound alone, but SIS, the installation of fluid, gives you the most dynamic pictures. If I had that and saw it in the chart and there is no hysteroscope, I feel confident for the most part. And then treating atrophy or just saying, whatever treatment you're going to offer, but not a transvaginal ultrasound alone. Definitely not. And we have really pioneered now at the clinic. We have 8 hospitals, 18 family health centers, and we've just kind of made our triage. Abnormal bleeding, you can't do a SIS with a 25-week size uterus, you know what I'm saying? But normal upper limits, normal uterus, maybe 14-week size, try SIS because sometimes you can't distend well. If you got those big intramural fibroids, you see what I'm saying? I love hysteroscopy for my post-op. I'm nosy. I like to look what I'm going to see. I like to see the patient who's come back, who's saying other indications. We've had 3 DNCs for miscarriages, abortions, retained products. And I look before I go in. Okay, because if they already have a bunch of Ashermans, yes, it's thickened, they can see something on ultrasound. Yeah, they have all that done. I'm looking because if and you want a baby, that scarring, if it started and then I'm doing it again, then I may put something in the uterus and keep it, a balloon for distension, deflate it a week or 2 later, have you come back, look once, maybe look a month later. So I like to be nosy. All my big hysteroscopic resections, my type 0, my type 1, my kissing lesions. I want to see how that uterus heals, especially when they want children or they're ambivalent about having children. So I see a lot of uses besides just bleeding in the thickened endometrium. The patients with leukorrhea, they don't bleed. And I think that's another thing that we do wrong in medicine, in gynecology. We ask patients last night, this was my mentor who's 85, and that's why I had to change the dates. She got ready to retire. She said, Linda, always tell my story. So I'm going to tell her story. Gynecologist, superb gynecologist, unnamed, came to me. She says, I think I'm having incontinence. I'm like, well, tell me more about it. It wasn't incontinence. You listen to the story. We said it again last night. No blood. So don't ask patients if they have postmenopausal bleeding. A terrible question in my mind. Have you had a discharge, mucus, watery, secretions? Are you needing to wear a mini pad? Is it pink? Is it yellow? Is it brown? Is it rusty looking? And then I ask, do you see blood? Because the patients will tell you, no, Dr. Bradley, I haven't had bleeding. What my colleague had was leukorrhea. My first book chapter I wrote, I can't remember for what book, the reviewer wrote back and I put down like 20 reasons why I do hysteroscopy, including leukorrhea. Oh, I never heard of that. Well, I've heard of it a lot. My colleague had a mixed Mullerian sarcoma, never bled. She is a lucky person who's still living 8 years after her robotic hysterectomy. So leukorrhea is another, it could be from the polyp. I don't know if it's a transudate. I don't know why some diseases give that. Some patients I love it after uterine fibroid embolization, uterine artery embolization. You can see fistulous tracts. You can see the debris within the endometrium. If you can sometimes see what I call the caviar inside the uterine cavity floating around from their embospheres that they're using. I can just go on and on, the foreign bodies.
Well, one thing that I think in your practice that is unique is that they're all being referred to you, not all, but many are being referred to you after they've had other folks see them and they're continuing to have problems, at least the ones you've described.
But that's not all true. I would have to, that they're not all, nope, everybody at the clinic.
Definitely not all.
It says find a doc. So the patient has postmenopausal bleeding, they put in find a doc at the clinic and you say what you're having, what side of town you want it. My name shows up. So some of them have never seen anybody. And they've done their own quote research. But you're right, it's a referral center. But I don't think that my practice is any different from the patients that I've never seen.
What about your partners at the clinic? Are they doing the same thing? Are they scoping everybody?
I would say yes. Yeah. A lot.
What's
majority.
Your setup in the office?
So we have 3 procedure rooms. Some people some days do cystos in that room. What is that other procedure? The Mona Lisa?
The Mona Lisa touch. Yeah.
I don't do that for the vaginal dryness. I'm saying you have 3 rooms that are set up and we're all given a procedure day. And so we try to schedule so you can just, same nurse. And now we have it where depending on who's in the clinic, you can do 1 or 2 go back and forth while one patient's recovering, the other patient, you're getting the consent and go back and forth. So it moves a little bit quicker.
So do you have a clinic day and then a procedure day, or do you do it all at the same time?
All in one. I was just saying some days, on the average, I would do 6 to 7 hysteroscopes. I think tomorrow I have 6, but I'm seeing new consults because I'm just back. I don't have post-ops, and there's really the post-ops I've started to do virtual because there's enough. If you hear from your patient after hysteroscopy,
right,
with the problem, in fact, I have a picture from one of my PowerPoints. I have a phone that's dangling. And it says no calls. Like you said, we don't have to worry about the incision site. It's red. It's not, I don't like to stitch. It's stitching out, blah, blah, blah. if the residents know, if there's my patient or anybody, if the patient calls after hysteroscopy, except for the expected withdrawal bleeding, I tell the residents, look at the path. If I took out a big submucous fibroid and they stop bleeding and a week later they bleed, I said, first thing you do is look at their path. If it said early secretory endometrium, if there was some endometrium, that means the next week they're bleeding because they're having their period. Because so I'm just saying you don't hear from them. So we see new and consults.
So is it a mix? You'll go back and forth between your clinic visits and your procedures and kind of bounce back and forth?
Yeah, half hour. They're set up in half hour.
And then if you have a new who you're just meeting, who you weren't planning on scoping, but you talk to them, get their history.
I do it. If I can, if I look and see that the next patient is something brief and easy. If it's an IUD, I don't know why they're sending me IUD insertions, but if it's something simple, it's like a 10-minute visit, I'll go ahead. Because a lot of our patients, to your point, are out of town and it's flown in here. And, it's hard to have them to come back.
Oh, yeah, we got folks from in-state that are driving 2-3 hours away. And it's a big deal to get here. So it's nice to be able to offer same day. But so one of the challenges we have, though, is, as a hospital, putting my hospital administrator hat in, we have prior authorizations we need. It's one thing to offer same day. It's something else altogether to have them get a big giant bill for it if it was not previously authorized. And those are the kinds of things.
We used to have that because I don't know what year it was. I initiated something was called One Stop Shopping Menstrual Disorders Clinic. Then for a while we had to wait to get the auth. Things that are bad where you're not getting paid, our administrators would tell us. I don't think we've seen that. And I've been there long enough. The last, say, 5 years for sure, since COVID.
What kind of scopes are you using?
So we have my workhorse, because I've been there forever, is my flexible 3.2 flexible. We have I don't want to say brands, right? Or do you on this show?
It's up to you.
It doesn't matter. Well, I don't know if you have to beep it out because, you go to a meeting, you can't say what you use. So they're all the same. 3.2 flexible. We have a rigid scope that's 5 that you can, like I would use to take out IUDs. I would use that when I was doing years ago, the hysteroscopic sterilizations in the office. So we have both of those.
So do you have a nurse? You're staffed for 2 rooms? I'm like logistically, right? Like I think I have 2 clinic rooms.
One nurse.
It just bounces back and forth. And then how do they clean the scope between?
Well, if it's the flexible, there's like a sterilization, 24-hour sterilization. We used to have a Steris. I don't know if this is a national thing, but nothing at the clinic, including colonoscopes, can be Sterised anymore. So that's when we had that. One point I had 3 or 4 flexible scopes only. And we could Steris just quickly. It's 30 minutes.
That's what we did in fellowship. You could just cycle them through and you could get
and
2 or 3 could get you 6 or 8 in the morning.
Right.
Yeah.
So JCH came through the clinic and also for colon and bronchoscopes and blah, blah, blah. So that's how I ended up with 9 or 10 scopes because I said, okay, guys, if we have to send it now for heat sterilization, I'm not threatening anybody, but that's all I can do in a day. So they ended up buying more. And then you have the development.
And that's been the challenge for me. Is we don't have a hood. We can't do that in our office.
They don't allow it.
Yeah. And then so that was when we redid our clinic space, but it's got to go down to, clean sterile. So it's got to get processed. And that's, like you said, that's 24 hours. And so that's a pretty big purchase, right? It's not buying a scope. It's buying a bunch of scopes. But, I think OR time's expensive. Go ahead.
Right. No, I was going to say, I've heard, and I don't want to give false things, but I've heard that the clinic may be switching to disposable bronchoscopes, disposable colonoscope, for doing a colonoscopy. So everything is becoming disposable because of this alleged cost. And I'm going to be quite honest. I don't keep up with that. I don't wear the hat of an administrator.
I can tell you that's the direction that we're going, that most people in this country are going. But there is no disposable, flexible.
No, there is not. But it bothers me. Until the AGL and last year's president, Michelle Kenney, talked about sustainability. I now am sick when I throw out food at my house. How much waste the average family for that is $2,000 a year. You don't think about it. How much waste. They talked about one OR, how many disposable things. So I understand like your administrator had, but boy, it bothers me that you have a scope and you throw everything away.
It's not things we ignore. It's an important piece of it.
Yeah, but the environment, I guess is what I wanted to say. Environmental issues, do bother me.
No, I think we have a lot of pressures coming from a lot of different ways. And, you have to, 100 years ago, doctors decided this is a business. And so, right, we had, the AMA, physicians have opposed nationalized healthcare in every form, I think up until the ACA. So it is what it is, right? So within that, we have to work to treat as many patients as we can. And there's some choices we have to make that are not perfect. And so it's nice to be able to say, we love to be able to offer this to every patient and do it real time and forget about prior authorizations. And let's do it reusables everywhere we can. But at the end of the day, like, doctors are incentivized to do what? To do procedures and to do a lot of them. And when you're limited by your ability to do one scope a day,
then you may have to make a different choice. I totally understand.
Yeah, I hear you. And I appreciate what Kelly's done. And there's no disagreeing with her. I mean, it's just the truth. But trying to balance that with the reality of the healthcare system, how do you, if we can figure out a way to make that a more financially responsible decision as well? Because at the end of the day, like, these changes coming at us now nationally are going to be a crunch on big hospitals taking care of sick people. So it is important to make tough decisions. So I think now these are all things that when we talk to administrators, it's important to understand all of these things so we can do what you do, which is advocate for your patients and stand up and say, this is the right thing. And how do we support that? And how do we build that business case? And that's where physicians learning how the system works will allow them to better advocate instead of just saying, oh, I want it. Well, let's build the case and tell them why.
Right. But I would also say, Mark, that expensive is missing a cancer because you're trying to save $300 on a procedure. Expensive is taking a patient back 2 and 3 times to the OR, maybe the same doctor and then somebody else. But some patients go multiple times within a year, 2 years' time to get a treatment that they could have had. And you're right. Sometimes I get to be the lucky person because someone else didn't do something. And my point is, if I could have on my tombstone is that she tried to encourage hysteroscopy. I think we should learn it. Why is it in a room for every meeting, it's the same thing? I just got a new computer. Thank you, Cleveland Clinic. And the guy wants to sweep my computer. I said, let me see all my PowerPoint. I went back to PowerPoint presentations in the early 2000s. And I was saying the same thing then as I'm saying now. The font looks prettier. The pictures now I can put in there. But the information's the same. How much more do we have to contend with before we can convince people that it's accurate? We talked about all of these things.
So this is where my interest in healthcare economics and all that began, which is AAGL sent me to DC twice a year to be, to learn about health economics. And it was a gift for my life to be able to be sent there and learn about this stuff. And what I realized is I hadn't learned anything in med school and residency and fellowship about how the business works. And what made me care about this stuff and what made me want to do this and what has made me want to go get my MBA is we can have experts do the best research in the world and prove that this is the right thing to do. But the reality is physicians are slow to change practice based on education. If you change reimbursement or the incentives that matter, you can change practice overnight. And if you decrease reimbursement for procedure, okay, so if Medicaid says, hey, we're going to pay less for a hysterectomy, guess what happens to the number of hysterectomies performed that next year? It goes down. It's not because there's less pathology. And so say what you want about people. This is not good or bad. This is not judgment. This is just the data. And so if we know that we can impact care, because at the end of the day, you and I have the same motivation, which is let's get the best care to as many people as we can. And if the reality of the situation is a limitation of that ability, then how can we understand the system better to sit at the table and make good arguments to the folks writing the checks to say this is the best way to do it. And so I think I appreciate your advocacy, and I think that the starting and ending with what's the best thing for our patients. And even with the work, as an administrator, the work I'm doing, it always, always, always ends with, are we doing the right thing for our patients? Because we're never going to make money on everything, and that's not the point.
But how about the medical legal reality when you say that documentation, my notes say documentation of visualized normal endometrium provides a stronger medical legal protection than just saying normal tissue obtained. or the courts expect patients to have use of high technology, which is, quote, the hysteroscope. And missed endometrial cancer diagnosis, I know you were saying that, a lot, is a growing malpractice claim. So, you know what I'm saying? So I think you have the administrative hat, but you also have the medical legal hat. And then you have the hat for the patient that's just trying to be a good partner, wife, worker, not stressed out because of all of this stuff, even for the polyps, even for the fibroids. I mean, you know what I'm saying? And so I don't know. I'm saying the same thing over and over again.
At the beginning and the end, well, we can begin and end with listen to your patients.
I agree.
Just because it doesn't, what you see is not on ultrasound, or there's stories that make sense. If you're not sure, continue to do that workup. Take a look, because there's stuff that's going to get missed on ultrasound. And if patients tell you, I know this is normal, but I don't feel normal, the answer is always trust the patient, listen to the patient. Begin and end with that. And I think that's a good place to stop. So as always, a pleasure to have you here.
Thank you.
Again, I look forward to seeing you. Hopefully we'll see you in Vancouver in the fall. Looking forward to getting out there and catching up with all of our friends. And best wishes to you, and tell everybody in Cleveland I say hello.
I will do that. And could I just say, let's take our best guess about what's wrong with you out of this. We're not taking guesses anymore. We're not guessing what's wrong. We're going to look and see and know what's wrong with you and lead you in the right direction. That's what I like to leave our crew with.
Perfect. And that's why you're here. We appreciate you.
You're so kind. I really needed this tonight, so thank you.
Well, no, we're lucky to get to have such wonderful guests, and that's the show. Our guests are the show, and we're very lucky. So we'll catch up soon. Take care. Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Ivan Orgodzinsky.
Show notes and social media by Emma Landenwich and Lindsay Beecham. Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.